All right. Let's go ahead and get started for today. So good afternoon and welcome if you're here for the first time. I know we've got a couple new faces for today, or welcome back to Communicating Health and Science. This is our second class meeting. We'll be going a little bit longer for today. We'll be breaking it up with some activities and things to do. I will say it'll be a little bit more lecture-based than usual, just because we've got some ground to cover just related to history and context about health and science stuff. So we'll get into some of that surrounding the history and context related to health and science. For those of you that are here for the first time, and just as a quick refresher for everybody, just as a reminder about what's available for this course on Canvas. If you go to the Canvas page for this course, the front page lists a schedule for the course. Each class, before class starts, so typically by about 1 p.m., I will be posting the slides for that day. That way you can access it. Since I know that the projector, if you're in the back of the room, might be kind of hard to see. You're welcome to access the slides on your device so that you don't need to write everything down word for word or take photos. I also post a video of the class after class ends so that you can refresh on that if you missed class or just want to review something. This week, the readings are available as PDF. I have a PDF of the first couple chapters to help you so that you don't have to use the textbook in the first week, but I am asking you to get the textbook starting in the second week of class. And also remember that the week 1 quiz that covers these first couple chapters as well as the syllabus is due this Sunday. The quiz is open note, open book. It's a combination of multiple choice and then a short essay section at the end. This Dupree textbook should be super cheap and accessible. Again, I recommended renting or buying a used copy, which is around $11 to $13. It should also be available in the bookstore. You should not be paying that much for it. You can use an older edition, and it should work out just fine. If this next week, as we're getting into the next assignments in the class, you're finding that you're not able to access the book or you need some additional help, let me know, and I'm happy to help you with getting that. So as a quick recap of the things that we went over last class, we did an introduction, got to know some of the people who were here the first day. We also talked about why health and science communication matters, right? So what, why do we care? And then we also did an overview of the syllabus and class schedule. Remember to review that syllabus for Wednesdays or for Sunday's week 1 quiz. Before we get started on stuff like instructions for today, does anybody have any questions about the class, anything that we went over before, something like that? If any questions come up at any point, feel free to flag me, let me know. Or if I'm going too fast or need me to cover anything in more detail, let me know too. So for today, we're going to be going over some of the basics surrounding health and science communication, different approaches and ways of thinking about these issues. We'll also be talking about history and context surrounding health and science, and some current events and issues that are really important to that as well. So this will be kind of a broader overview. Also, as a note, I know that we have longer class meetings. They're close to 2 hours. So, you're welcome if at any point you need to use the bathroom, get a drink, any of that, right? You can. I will also, kind of around the midpoint of the class, give everybody a 10-minute break where we can just, refresh ourselves, go out, do something to help ourselves feel better so that things are a little bit more palatable. I also do not anticipate that we will go all the way to time for every class either. So I know like a big 2-hour block can be really draining, and I want to make it a little bit more manageable. So what I want you to do is just take a couple minutes on your own to write or type, and you don't need to turn this in, but I am going to ask everybody in the class to share. In your own words, what is health? And that's a super broad word, right? But I want you to think about what that means to you. You could give an example of what health means or how you understand what health is, but just take some time to jot down what that word might mean to you. So I'll give you another minute or so. Like most of you are about done. So what I want us to do is to go around and have each person share. And when you share, remind us your name. And if you're here for the first time, which is a couple of you, I'd like you to just take the time to share. What were you up to over spring break? What got you interested in taking this course? And how might you describe what your own experience is with healthcare is? So let's start on this side, going down this row here.
Here, I said, help people balance between one's mental and emotional fulfillment, completeness, and the physical state of one's body as it relates to one's sickness and overall.
That's super thorough. I like the way that you're capturing mental, emotional, physical, all of those elements there. Back row here. Go for it.
So my name is David.
David.
My own words, health is the physical.
Yeah, you're here for the.
Yes, I'm here for the first time over spring break. I supported it. All aspects. Now that I've tried my healthcare, I would say I've overall had pretty good experience. One being with my eyes.
Yeah, awesome. Thanks for sharing. And glad to have you in the class today. This is new course and a kind of different angle to explore communication with. So I think it'll fit well with what let's move back in.
Hey, my name is Justice. My words, help with being capable of physically, mentally, emotionally performing the best, relates to achieving the maximum potential. Over spring break, I was mostly just working on finishing my project. I was interested in taking this course because something stood out and I'd rather things out available as much as I can. And a lot of experience with healthcare, but my mom works in the hospital, so I'm a partner.
Yeah. Having like family connection to that for gives you a lot of kind of unique specialized knowledge, right? Like my parents were both involved in like therapy, human services. So there was a lot of conversation stuff there too. So glad to have you in the class, Justin. Thanks for sharing a little bit about what you're doing. So let's move on over to this side.
My name is Angela, and I'm really going guys, but I just put health is like how you are feeling, whether it is physically or mentally.
Yeah, right. And that's an important thing to add into because health is feeling, it's an experience, and what it is that we feel differs a lot depending on, I think, the culture, context. So that element of it is hugely important. Come on down.
My name is Lila, and the way health is basically just the body, such as in being important to physically to the sport, also what that word specifically.
Concussion. Yeah. Right. That's a challenging topic, right? Because there's been a lot of discussion about concussion and physical injury in sports and things that should be done to address or deal with those types of issues too. So good addition to add to our overall context there. Move on now. What does it mean to be well? And how does that differ depending on situations?
And I said that what's also the state of the mind about
Mhm.
and with the bad mental state, your behavior like if you were injured.
Yeah. So, Kane, I really appreciate you and other folks in the class bringing up this idea that health is more than just physical, right? And that the impacts of like mental health related issues really can reverberate and impact you in a lot of different ways.
Hey, I'm sure, like everyone else, that's about like the state of being well, that is physically, like you can just like, I guess it sits without like the words, without.
Yeah, right. Like a lot of times, it's kind of like with a car, right? If you drive a car or a bike, where it's like, it's nice when it feels like things are normal and not acting up. And oftentimes we notice, and it becomes an issue with like our body breaking down or car breaking down or bike breaking down, right? You have an issue that comes up and suddenly it gets brought into focus. Health is something we don't normally think about all that much unless it is impacting us negatively in some way. And then let's move on here to this side. Go for it.
Like for me,
Yeah. Remind us your name one more time. And let's move back up.
My name is Grant. I put health is a state of life where your mind and your body function properly.
Right? So this question of functioning or being the level that they need to be is important too. So I really appreciate you all's definitions, and I think that these really get at a lot of what we're talking about when we talk about health and what health means. So kind of boiling it down as broadly as we can, the World Health Organization, right, WHO, defines health as a state of complete physical, mental, and social well-being. Again, getting at that triad that folks like Garrett and Kane brought to the table, right? That health is about more than just being physically fit, physically healthy, whether or not you have an injury. But mental health is crucially important too, right? Feeling exhaustion, burnout, depression, and so on, more than just like defined medical conditions, but also in terms of the ways that it impacts your experience day to day. And not merely the absence of disease or feeling like we're being committed to an institution or program, right? The idea that it's being healthy is more than just being not sick. That health is an affirmative experience. You're feeling good or positive in those three elements of yourself, however you might choose to define and determine what that is, right? So when we think about and break that down, that means, as you all brought up, that health is holistic. When we're talking about health and science in this class, we're not just talking about physical injury or needs, right? We're also talking about those mental needs and support, especially in the context of things like COVID-19, disparities in healthcare, the ways in which things such as race and gender impact healthcare, and then also social needs, right? Our relationships to other people, and the ways that those needs might or might not be fulfilled. The experience of isolation that many of us have had over the last couple of years has been a serious consequence on our health in a lot of different ways, right? Not just in the ways that might spill over physically and mentally, but also that as human beings and social creatures, we wanted to feel those needs fulfilled. And then, right, someone might be sick, but live a healthy and meaningful life. And not being sick does not necessarily mean that somebody is healthy. For instance, somebody might be chronically ill, right, or have a condition that means that they're sick on a regular basis, but within the context of their own life and means, they can still be healthy by their own terms. If somebody has a chronic illness that is not necessarily curable, right, there are still ways to feel health and to feel some degree of social illness. Talk about that in just a second. consider to be healthy and to be the way that we should interact in society, right? Seen a lot of discussion about that in the context of issues like COVID-19 and like what we consider or not to be healthy behaviors. If you've followed or seen things related to a lot of like trends in dieting and fads and critique of dieting, right, in general, right, we know that there are all of these different approaches to what's considered to be well or healthy or what we should consider to be healthy. A lot of conflicting information, top science, and issues with source credibility. So I want to give you one example of deaf communities and cochlear implants. How many people are familiar with what a cochlear implant is? I've heard of this used before. Right, so several of you. So this is an interesting, I think, kind of timely thing to explore. If you were following stuff with the Oscars, and I don't mean that thing, I mean Best Picture winner, right, Coda, that is a term used to describe a child of deaf adults, right? So the premise of the film is that the main character is hearing, but the character's parents are deaf, right? And if you look at it in the deaf communities, there's some critique and pushback against it. Some people say, hey, it's great that deaf actors, including the best supporting actor, who got an Oscar, are playing deaf characters because there's a history of like non-disabled actors playing disabled characters. But also some criticism of the ways that deafness is portrayed in the film, right? But deaf culture is one of the greatest examples of differences in what it means to define health and what it is to be healthy, right? For a lot of folks who might not be deaf or might not be familiar with deaf issues, a cochlear implant, which is designed to allow people who qualify, who might otherwise be deaf, to hear through the use of transmitter and similar devices, might be seen as a really good thing, right? Wow, with an implant, somebody's able to hear, process, and understand information. What a great thing, right? Under the belief that access to senses, including sound and hearing, is inherently a good thing, right? So for a lot of us, that would be a given. However, many members of the deaf community have actually pushed back against the use of cochlear implants. And you have many people who are deaf who might actively choose not to get them for themselves. For instance, being deaf might be a core experience or aspect of somebody's identity, right? The deaf culture is developed through the use of sign language, through the use of communities and methods of support, right? If you're familiar with Gallaudet University, that's an entire institution that is for deaf students. So there are other members of the deaf community who say, I don't want this, or even use cochlear implants as something that poses the destruction of deaf community and culture, right? And this is a tension that we see in a lot of other communities too. For some, health might be the ability to hear. For others, one could be perfectly happy and healthy being deaf, right? So culture, what we define as health and what we define as being well are going to be pretty different depending on the situation. So here's another pretty broad question. I know that we have a lot of people here who have been in another communication class, but some people that are here for the first time. So let's break down what communication is. Does anybody want to take a stab at, in the most general way possible, defining what communication might mean? Yeah, go for it, Angela. Yeah, you were doing this in my last class.
Okay, can I just say what I said?
Sure.
Okay. Communication is not only about speaking to a person, it's about listening and being able to have a message, and it also includes nonverbal cues such as nodding, facial expression.
Yep, absolutely. So a couple of you are in my calm theory class, and we talked about this as well. But I like to start out each class by talking about defining communication, right? Communication is about how we use symbols to convey reality and meaning to other people, right? If you were like me, when I was younger, I used fridge magnets to like make words and poetry and fun things like that, right? Each of those words being a symbol. Communication, for those of you who are taking your first communication course, for anybody who's taking their first phone class. Just about everybody is taking a phone class. Right, so as you might know, from other classes you've taken, communication can be verbal, as Angela mentioned, nonverbal, use of facial expressions and so on. It can be with two people, it can be in small groups, it can be in large groups or organizations. It can be mediated, it can be synchronous, asynchronous. It covers a wide range of experiences. So when we're talking about health and science communication in this class, it's not just about a patient and provider, right? It's not just about that relationship and what interpersonal communication looks like. It also looks at health campaigns, social issues, how we communicate about health in groups, right? In fact, one of the popular elements of patient-centered care is the idea of a health communication team or network of multiple people that work together with you. So we're covering a lot of different areas. So when we put those two things together in defining and talking about what health communication is, I think there are a lot of kind of crucial things that we need to know and look at, right? How many of you have ever had to fill out an intake form? Should be just about all of you who have seen some type of doctor or eye doctor or professional stuff, etc. An intake form, right, is paperwork that you might be completing either on paper or digitally that provides basic background and demographic information about you, right? In this way, communicating about health and science begins before we actually have the interaction, right? There's a lot that's communicated on something like an intake form. For instance, what does one do about disclosure of things related to race? For instance, there are some intake forms that only allow people to choose one of like a multiple choice option to describe race, in which case people that are bi or multiracial find themselves unable to find themselves represented or heard in that form. Also ways in which things such as gender, right, and sex assigned at birth might be included or not included, right? If somebody is trans or non-binary, how does somebody allow that experience to be expressed or affirmed in an intake form or not, right? There are a lot of anxieties there. Also, filling out a big form like that can be pretty intimidating. It can take a lot of work and time. You might find that you're having to fill out and indicate your primary position and you don't have one, right? So there are a lot of like gatekeeping and other types of barriers that can happen. So from the very beginning, right, our communication about health and related issues is impacted by things like a form, by things like public awareness and campaigns, also by the knowledge and information that we have currently. For instance, the information that we might have received or know related to COVID-19 and the sources that we have for that information are going to impact the way that we look at health and look at surrounding COVID. So health communication starts very early, and it's about the way that we both seek, right, try to find information for ourselves, process or cognitively make sense of information, and share information about that, right? For instance, if COVID-19 is just starting, right, you fast forward to what feels like a decade ago, 2020, and you're hearing about this weird little virus that is spreading, and cases are starting to be confirmed in the United States. You are seeking out information. What is COVID-19? What is it about? People are maybe starting by making jokes and referring to it pretty lightly. What is this virus? What's going on? How is it spread? What are some of its social and psychological impacts? Processing. How are you taking in information about COVID-19 and using that to make sense of your life, the ways that you might or might not change your social behavior, things that you do, right? I had an era where we were using disinfectant wipes on like every grocery item that we got, right? Because that was a way that we were processing that information. how do people share health information, right? One of the biggest problems that we've seen in a lot of discussions surrounding health and science are issues related to source credibility, right? There's a lot of issues related to pseudoscience information that might not come from credible sources, right? And so I think it's important for us to engage in critical thinking when we're receiving and processing health information. One model that I like to use and talk about are what are known, according to James Gunn, as the three texts of source credibility. Kind of a fun way to think about your sources. Who the heck wrote it, right? Who is the author? What is their background? Are they somebody that's an expert in that field? Who the heck paid for it? If you're reading a BuzzFeed listicle about the ways that dog food is healthy and it's sponsored by Purina, they're probably going to want you to buy their Purina dog food, right? And when the heck was it published? That is, more current information and sources are generally more useful and credible, right? That's an important part of health communication in that process, right? As a field, as an area of study within communication, it came up in the 1960s, right? And one thing that's really cool is that it's very interdisciplinary. So if you find yourself in health and human performances, you're a double major or you're like minor, and you're involved in communication in other fields, health communication has come up because people involved in psychology, in sociology, in medicine, many of the hard sciences, right? It is important as a medical issue, but also important as sort of a social and cultural issue as well. That is, we can get a lot of information and scientific data surrounding health, but that doesn't mean a lot if you don't know how to talk about that and share that information, right? In the same way that a lot of more social sciences can help us think about culture and related issues, but gain the backing of sort of understanding of medicine and science that health communication brings to the table. Health communication, like you were saying, begins ahead of time. It begins when you're in the waiting room. It begins in an intake form. It begins with the information that you have about yourself and about your body that might impact the way that you choose to communicate about issues, right? For instance, oftentimes people who have difficult situations with healthcare, with getting their needs met, oftentimes will like come in very well prepared about issues. Remember last class, Garrett was mentioning the case of a doctor who like says, "Oh, you're such an interesting case with your eyes," right? Every single time, as if it's the first time, right? And so there's interesting examples here of how we find ourselves needing to advocate and share our experiences, but it doesn't always feel. Health communication is about relationships, about a two-way street, right? Some of you mentioned that you have involvement or are seeking sort of in professional careers in life, looking into health and related fields. So that relationship is a two-way street. It involves a patient feeling like they're being heard and listened to as a provider, being clear and helping them understand the message, and shows they really care about and empower that person as a human being. And it also means that a patient is somebody who's open and willing to take in that information, who's willing to ask questions, right? And to seek out clarification if things don't go the way that they want them to. So all of these things are crucial to know in terms of defining what health communication is. It's interdependent and draws from a shared understanding from a patient and provider, from somebody that's circulating a health campaign and a talk, and so on. How many folks have been to OMSI? Few of you, right? So OMSI is the Oregon Museum of Science and Industry. I used to go there all the time as a kid. You know, it's this gigantic museum that has a lot of rotating exhibits in Portland. They also do some really fun stuff. Like sometimes they'll do very interactive and hands-on things. I remember there was a little station where you got to make a boat and give it a little sail, and you got to watch it kind of float along the water, right? That's an example of science communication, and I think a really cool one, right? When you have like interactive museums or exhibits or things like that, right? Those spaces basically communicate and educate us about science and about related fields, right? There have been some really cool, for instance, initiatives that have kind of educated and supported initiatives for women in STEM, for instance. And things that basically educate and get us excited about science are really good examples. The authors Byrne, O'Connor, and Sutherland in an article in the journal Public Understanding of Science developed what I think is an easy AEIOU method of thinking about science communication. A is awareness, right? We use science communication to make ourselves aware and familiar about science. So again, you're learning how to build a sailboat and learning about aerodynamics. You're learning like the history of Egyptian tombs and mummies, right? You're learning science and context. Enjoyment and appreciation is another element of science communication, right? My extended family, we have somebody who is a professor who's really focused on Christology, right? And really enjoys the super focused area, right? The scientific method and process about understanding and appreciating science for its own sake. Also, right, interest, showing that you care about and are invested in science as a thing to do. Opinions, of course, develop over time. How do you feel? What is your attitude surrounding an issue related to science? Obviously, examples like CO2 emissions and climate change come to mind as politically and socially heated ones, but that also develops through that process of science communication. And lastly, understanding, right? Understanding what science is, how it relates to society or relationships, and so on. So, science communication kind of gets at that AEIOU, gets at how we understand and convey and relate information about science, right? This is a course where health and science are really closely tied. As we'll talk about in just a minute, as we get more into the history and background of health and science, these things are really pretty intricately connected in a lot of different ways. It's also important to think about and situate this in the context of culture and situation. How many folks watch Queer Eye on Netflix? Not very many of you? That's okay, right? So there was some interesting controversy that came up in one episode, right? The premise of the show is that the characters or the people on the show basically give somebody a makeover, right? They change their living space, they change their clothing, they try to provide some like recipes and food and lifestyle changes and so on. There was one episode that gained some kind of interesting and significant controversy and discussion. Picture down here is Wesley Hamilton. And in this episode, right, and part of giving Wesley's makeover, Wesley uses a wheelchair. However, Wesley does not consider himself to be disabled, right? And there was some critique and pushback and discussion on a lot of different perspectives about whether or not Wesley choosing to not consider himself disabled was a good or a bad thing, right? And one thing that I think was important to point out was the cultural background and experience that Wesley came from, his understanding of disability in his own life, and how it was used in his family and community context was that disability was associated with weakness, right? He did not choose to identify with that, but there might be other people who interpret or see disability in a different way. Disability as a strength or core part of who that person is, right? So missing in a lot of the discussion and debate about whether or not it was a good thing that he didn't consider himself disabled was a lack of understanding of Wesley's own perspective, experience, and the ways that things like culture shape what he understood about things like disability and health, right? So those things are important for us to think about in health and science, that it's not just about us objectively identifying is somebody healthy or not, but about how those cultural and social factors play into it. Not all healthcare experts are sensitive to culture, beliefs, and other related issues, right? For instance, one of the things that we'll be getting at in a little bit is the history of issues related to racial segregation in healthcare and the ways that those exacerbated health disparities, right? For instance, there is an incorrect stereotype that was common in a lot of medical fields, and unfortunately is still common to this day, that patients who are not white have It's not true, but that assumption might mean, has historically meant, that a lot of doctors are giving less anesthesia or care to patients of color. Additionally, there are rules related to things such as displaying or sharing emotions. Depending on the culture or background somebody might come from, somebody might be less willing to share or disclose their emotions or feelings, including feelings of pain or discomfort. And those things are important communication indicators if you're working with a provider on something like a surgery, right? There's differing accounts of what's considered acceptable information. That is, how much do you disclose or share about your health, whether it's in this class, whether it's with a provider, and so on, right? There's issues of privacy and how we talk openly about issues. For instance, one thing that I've really appreciated over the last several years is that there's in many ways a destigmatization of mental health services, of therapy, and so on, right? Obviously, there's a lot of barriers, including healthcare and costs associated with finding and working with therapists, but there's much more open and frank discussion about people who see or talk to a therapist than there's been like 10 years ago. That's great. There are also differences, as mentioned, in cultural displays of showing and sharing elements about identity. So it's important for us to think about that the idea of health and what it means to be healthy is really significantly impacted by issues of culture and identity. We'll get at this a little bit more when we talk about some of the Indigenous and First Nation perspectives on health as well. So some of the reasons why the things that we talked about so far matter, right, include the idea that understanding and doing good health and science communication help us to meet our medical goals. That is, what do you want out of an appointment or visit? If you're not feeling good, if your pet hurts, or if you're a provider who wants to make sure you're identifying and supporting your patient, good health and science communication ensures that those goals are being met, that patients understand their options, that you feel like you're being heard and the issues you have are being understood, and so on, right? Communication is key and a cornerstone of what we do, because at the end of the day, right, short of using technology such as stethoscope, X-ray, or other ways of testing, a lot of the health communication process is somebody sharing and disclosing what they're feeling and an expert trying to make sense of that information. Enhancing your well-being, of course, is a crucial component too. By improving how we communicate about health and science, ideally, we make our needs met and that we find ourselves more healthy. Health and science communication save time and money, right? There are cases of, disasters in healthcare related fields where people have, died when they didn't need to or not received the care that was crucial to their survival. We also know that preventative care is much more affordable than care based on a crisis or a condition in the moment, right? In other words, when we look at some of the differences in spending based on countries, countries that prioritize preventative care tend to have much lower costs associated. Preventative care is about preventing someone from even having a condition that requires medical or health intervention, right? Think about catching something like cancer very early and being able to use something like surgery or like lighter chemotherapy versus late stage where there's a lot of time and money and effort that goes into things such as hospice care and end of life care, right? And also making the most of what we have, right? The idea here being that the scientific method and the way we gather information is not perfect. As we know, right, we're forming questions and hypotheses and constantly trying to get more information. So health and science communicating well is about making those interactions go better and improving that entire process overall. Some of the reasons that we do what we do. As we think about it, right, related to contemporary concerns and issues, as I'll be asking you to explore in a little bit, right? There have been a lot of issues that have come up that have made issues of health and science especially important. This was a report in 2018 about the per capita health expenditures faced by countries. The United States is right up here at the top at 10,586, right? Whereas we go down, we see differences in countries in the amount that they spend on healthcare on average. And again, a big factor about that is how much is invested in things like preventative care, which is able to really drastically lower healthcare costs. Obviously, COVID-19 has been a major contemporary concern surrounding healthcare, not only risks and impacts that it has, but also the way that we know or go about information, its interaction with policy, what shouldn't be done surrounding masks, vaccination, and so on. And also, as it relates to political and social policy, right? We also know that we're at a kind of unique point because more and more every year, we have baby boomers, even starting to get into Gen X, right, where we have retirees. And that means we have an aging population who's more impacted by health issues and is being added into Medicare and Medicaid, right? So there are concerns there regarding the economic impact that things like Medicare can have, particularly knowing that there's a larger population that's going into the system. What is the ACA? People familiar? What does the ACA stand for? Have people heard the term Obamacare? Yeah. The ACA is the Affordable Care Act, known in the more political context as Obamacare, right? In 2010, it offered some pretty significant changes to healthcare in the United States, right? There was a lot of controversy and discussion about and debate surrounding these changes, including things such as an individual mandate. We've seen changes to healthcare, including the elimination of an individual mandate, and some of the changes in health reform in the United States, right? Some of the changes in healthcare policy are still discussed to this day, right? There's a lot of political and social discussion about what changes we might or might not need to make past the ACA. But the ACA is really, whether you agree or disagree with it politically or not, an important marker that has led to some pretty huge changes in our healthcare system in the United States, right? Thinking all the way back to some of the ways that Medicare and Medicaid were first instituted in the United States. We talked a little bit about preventative and holistic medicine. Holistic medicine being the idea of focusing on people as a whole, right? Considering an array of physical, mental, and social needs. A lot of holistic medicine approaches actually have an Eastern rather than Western origin. And also, another issue here is this idea of patient empowerment. It's become a lot more popular and a lot more of a focus on the needs of empowering and supporting a patient and feeling involved, understood in that process. And then lastly, we've seen a lot more use of e-health and telehealth, right? Where appointments are conducted remotely using things like Zoom, even some sources that actually use things like text or have like a text line to provide support. And so while there's been a shift to more face-to-face, there's still a lot of like online ways in which health communication and information is being shared remotely. So what I want us to do is I'm going to split us in half and have two different groups. So there's two major models that we'll be talking about, the biomedical model and the biopsychosocial model. These are referenced in your book, but also if you do some searching online, you'll be able to find some definitions of these. And what I want each team to do is to take some time to research what this model is as it relates to health, and then have one person in your team to share the answer to these questions. First of all, what is this model? Second of all, if somebody came to the hospital and said they were, quote, feeling down, how would this model help their needs? And then lastly, what might be some of the strengths or weaknesses associated with this model? So this might be 5, 7, 10. So let's do starting with Garrett, 1, 2, 3, 4, and 5. So we'll have this group of 5 do the biomedical model. So we'll have 1, 2, 3, 4, and 5. The second team focus on the biopsychosocial. So again, feel free to move over to your group. Take about 10 to 15 minutes to research what this model is. Jot down some answers to these questions and prepare to have somebody in your group who will share these answers with you.
Basically, looks like
contract, right? And then like you sort of allowing people to like live with the comfort. Sometimes that like within this participation might be. Medical. So I'm hearing some good stuff. Take about 2 or 3 minutes and make sure to have a person in your group who will be able to share. Go ahead and finish up and see on this side. Yeah, for grad school. Okay, where else?
I just went to Snow College, so.
Oh, yeah.
In the middle of nowhere.
My partner's extended family is near Thai.
Oh, yeah, okay, well, that's right
Yeah,
there.
yeah.
Yeah, I was in the worst place. It's not like, yeah.
It had a bit of charm, but it felt like it had to turn onto a loop road and then another loop road.
Yeah, I took you through back to those.
Yeah.
Not fun. I should have went to Dixie State.
That's where I thought for you.
Really?
Yeah.
I was there last week.
Really?
Yeah, just walking around.
Yeah. I was there, it was a temporary position. I was only there a year and I worked remotely, so I didn't really get a whole lot of time to get to know people there, but it was, you know,
So cool.
good, yeah, it was a good set of people to work with and, you know, you're saying about the parks down there. It's awesome.
Did you teach college?
I did, yeah. We do. All right, so let's hear from both groups now in terms of what you have at this stage. So let's talk about these two different models and then we'll take a break. So let's start here with the biomedical model. What do you all find in terms of what this model was? How it would address somebody who went pulled down with the brain.
And this model, so this information is not quite clear. This is like I was just focused on my students. And it also like focuses on the things, this is focused on prevention instead of treatment.
Right, right. So this biomedical model, right, suggests that there are physical models or physical problems that need physical solutions, right? It suggests there's this defect or issue or injury or thing that this person comes to the table for. And like you mentioned, right, there needs to be some intervention or cure or action to address that. It's got a lot of limitations you brought up, right? It doesn't necessarily consider social, mental health, or like context, including culture. But one advantage is that it can be very direct. One thing we'll be talking about in this class is that over the course of the past several decades, right, as health and science is being adopted about more and more popular, to make things as efficient as possible, visits got shorter and shorter, right? There's a good chance that you go to the doctor, you know, you're with a nurse or somebody that's helping you, and then you're waiting, and then the doctor shows up for like 5 minutes, right? So a lot of times it's efficient, but sometimes that efficiency comes at the expense of losing crucial information. How about the biopsychosocial group?
It's a biopsychosocial model, holistic approach,
Mhm.
and focuses on mental health. We use this model to diagnose the symptoms or fracture,
Mhm.
and it's more broad and it focuses on everything that goes into
Yeah.
And this model would have a visit similar to how a visit to a PCP would go. There'd be a lot of varying questions like how your life's going, what you've been doing, and the conversation would be more personal.
Yeah.
And the negative would be it might be inconsistent and it's not specialized, and it could take longer to get a diagnosis, like in therapy.
Mhm.
And the positives are it's more broad and varying, which means you can get answers you couldn't have with the specialized questions of the other model, and it's more personal.
Yeah. Awesome. Thanks, Kane. I think that your group did a great job of describing, you know, this as being a more holistic and well-rounded model. That does help in considering a lot of the things the biomedical model might miss. But again, as your group brought up, it could also be less efficient. It could take longer. It could cost a lot more money, right, for people to continue to go to appointments to the point where they get the diagnosis that they're looking for. And because it's more interpretive, you know, it might be more important to get a second opinion or outside perspective too. So I appreciate both groups sharing. These two different models, right, are two major ways of thinking about health. I would say that broadly, we've moved more toward this biopsychosocial model, but there's definitely context and situations in which the biomedical approach is used when there's specific crises or health issues that require intervention, right? So both of these models, I think, are important ways of thinking about health and situating what we'll be doing in this class based on some of the assumptions and beliefs that come from each of these parts. So let's take a break. Take about 10 minutes or so. So it's about a little after 3, let's reconvene at or a little past 3:10. Feel free to grab food, water, use the restroom, do whatever. When we get back, we'll be talking a little bit about some of the history surrounding health and science in a little bit more detail. So it looks like we've got everybody back. Again, I know like a nearly 2-hour block can be torture, so I hope having a bit of a break in between is a little bit better. So if our discussion earlier was more about understanding the core kind of nuts and bolts of what health and science communication are and why they matter, I want to use the second half to place things in a little bit of history and context, and give you a super abridged discussion of history in health and science communication. That way you kind of know where we're coming from for this talk. So the kind of origin point for the study of health and science goes all the way back to 28 BC. Who pictured here on the right is Imhotep, who was considered sort of ancient Egyptian first known physician and was compared to the god of medicine at the time. And this is very kind of murky. We don't know a whole lot about Imhotep and his background, but we do know that this is a starting point in thinking about health and medicine, which took on what we considered a religio-empirical approach. And if you think about the history of studying health and science and what that history looks like, what you'll notice is that there's this push-pull between approaches that are based more on kind of empirical science, but also the role of spiritualism and the study of religious beliefs as well. How many people are familiar with the Hippocratic Oath or heard the Hippocratic Oath before? What is the Hippocratic Oath? 3 words. Yep, right. So the Hippocratic Oath, do no harm, is what many doctors or medical professionals are required to agree to or adhere to, right? It's a principle or ethical belief that guides a lot of people who practice health and medicine. It also gets used in media a lot, right? When we see depictions of doctors in media, like in shows like House, right? This idea of doing no harm is at the core of ethics. And that comes from Hippocrates, who was a Greek physician about 460 to 370 BC, lived to about 90 years old. So at the time was clearly doing something right when it came to managing health, right? And Hippocrates is considered the founder of what we now know as scientific medicine, right? The Greeks were kind of famous for developing a lot of sciences and study that we do to this day, including a lot of things related to mathematics, chemistry, and so on. Scientific medicine is no different. The health is not this thing that's purely spiritual or purely religious, but also something that we can study like a science. That we can do research to examine and develop findings about what science is. Obviously, at the time, he was drawing from very limited information and resources, but there's nevertheless important context and information that we use to this day. One thing that I think is kind of under-discussed and looked at, right, is that if we're tracing the history of the study of health and science, it's not just how, like, the United States or European countries started to develop health and science, right? Because the study and the use of health is something that has happened throughout the world and developed in a lot of different perspectives, and contexts throughout history. There's actually a really great website that I'd highly recommend checking out called the First Nations Health Authority, who basically does this entire project in history where they're talking about the history of health as it relates to many First Nations and Indigenous contexts. And it's a great way to, I think, address a historically under-discussed component of the history of health, right? That a lot of Indigenous and First Nation populations developed a very clear understanding of health and how health information was shared. And it's important to place it in context with issues like colonialism, the spreading of disease, and the ways that that had a unique and disproportionate impact on First Nation and Indigenous populations. I'm going to show a short clip from their video project that is a history of examining health and related issues as it relates to First Nation and Indigenous people. But there were some unique factors that were happening at the time, right? Prior to exposure and colonization, many Indigenous and First Nation peoples had a fairly lower population density, which meant things like diseases did not spread as rapidly. It also came with very active, physically and otherwise populations. And the lower population density meant that there was fewer spread, as mentioned, of issues that we might see currently. Under a lot of First Nation and Indigenous perspectives, a lot of health information was conveyed orally, like the use of oral history and sharing of tradition, including medicinal properties and things to do, for instance, to treat a wound, were things passed down in a generational context. In fact, in a lot of Indigenous and First Nation tribes and groups, there would be dedicated professionals, for instance, people who took on a role, depending on the culture, that might be known as a shaman, right? Who would take on a medical expert type of role. But then, when we think about colonization, including European colonization, right? It brought about a unique set of challenges for a variety of reasons, but one of them being that for First Nation and Indigenous peoples, the introduction of infectious diseases from European countries, including smallpox, influenza, measles, and whooping cough, were not things that First Nation populations were biologically prepared for, right? They hadn't encountered many of these diseases prior, and therefore it posed a unique threat and shock to bodies compared to many of these conditions having already been spread or circulated or exposed generationally in European countries. So I wanted to share a short clip here from this project that gets into some of the components of the project here in wellness and Indigenous history.
Hi, I'm Dr. Evan Adams, Aboriginal Health Physician Advisor for BC. The video you are about to watch will not only tell you something of the history of First Nations health in BC and how First Nations view health, but will tell you about an exciting and groundbreaking First Nations health initiative, a first for Canada, happening right here in BC, the Tripartite First Nations Health Plan.
This first song is a tseke. This is a chant that we use to call our ancestors to us when we're going to do ceremonies and rituals or anything of importance. These chants call our ancestors to be present with us and keep us dignified, honest, and focused on what we're doing.
Today, healthcare gaps exist between First Nations people and other British Columbians that must be closed. As First Nations people, we have always had the knowledge to look after ourselves. Our families and nations use language and stories to pass on health knowledge.
Learn from very young by stories, by lessons, and like the stories were, we always said when the kids, we heard that before, and the old person would say, if you're smart, you're going to be listening the next time, and there'll be some more words added when you are grown a little bit. We can't give it to you all at once, but if you're smart, you're going to be capturing this. Fill up the hundreds of pockets in your body, in your brain, with all the things that you learn.
In my childhood, I actually
Right. So I think it's a really interesting exploration of history and context as it relates to the study of health and science, right? That this project, which is looking at First Nations people in areas including British Columbia, right? As we kind of talked about, draws from experiential knowledge, the sharing of oral history and tradition, and the way that that knowledge itself could be considered a form of health and education. And again, gets at the idea that health and medicine and our understanding of it is happening in a lot of different contexts. In the context of Europe, right, and the overall expansion of perspectives on health and science, we noticed prior to the Industrial Revolution, right, so leading up to the 17 and 1800s, we were starting to notice this disconnect and tension between scientific approaches to health and more medical and spiritual approaches to health as well, right? For instance, one perspective known as medical spiritualism was this idea that bad health was caused by supernatural force, right? That there was like some type of demon or being living inside somebody that was a cause of their health issues. One interesting thing to note is that barbers actually were a main source of health and surgical intervention early on, right? There was a kind of trope of a barber who would like pull out a tooth for you and give you whiskey, like as an anesthesiac to help you, so that you could get that tooth pulled more easily. It's interesting to note that this type of more primitive surgeon role was developing. And also the idea that a lot of family cures and home remedies were developing. Obviously, a lot of cures and approaches that by today's standards, we would not consider to be good practice, but were what were available at the time. For instance, the idea of bloodletting or letting somebody bleed so that it would cause whatever disease or illness they had to leave their body was one example of a home remedy approach that we look at now and we might be really anxious about, right? So in contrast to that came Descartes, pictured here. And Descartes put forth the idea that it's crucial for us to situate doubt when we're examining health and medicine. We kind of took a step back from some of the approaches that were focused on supernatural explanations for health issues and said, we cannot believe the cause of health issues unless it can be proven or demonstrated, right? Additionally, Descartes brought together this idea of a Cartesian dualism. The Cartesian dualism suggesting that there is a distinction between your body, right, your physical self, and your mind or your soul or your spiritual self. We can see traces of that now when we think about like holistic and biopsychosocial methods, when we think about the idea that there's these physical needs met, but also the mental and social ones happening too. So Descartes put forward the idea that there is that distinction that exists in how we feel and experience and engage with issues related to health. When we moved into the Industrial Revolution, right? So when we moved toward around 1760 to 1830, we started to notice that there was a lot more involved medical practitioners and experts, right? There were people that were a lot more qualified and came forth with expertise on how to deal with health and social issues. That we moved less from folk medicine or home remedies and more toward professionals. But at the same time, of course, there were some flaws and problems with the ways that we thought about medicine and health too. One of them being this idea of germ theory, that all disease originates from little germs, right? We know that disease comes from a lot of different sources or causes, but we were starting to see the development of theories that were examining sources of disease and illness that were suggesting that it might not be visible to the eye. You might be familiar with this classic logo. This logo is from the AMA, or the American Medical Association. The AMA was developed in 1846, and under the AMA and its development, it meant that there were more and more medical appointments. There was more of an institution and structure behind those appointments. But it also meant, as we were starting to talk about, that the appointments themselves got shorter and shorter and shorter, right? More people were coming to see doctors. There were only so many doctors available, especially if we think about issues of gender and race, right? Only so many people could even be doctors in a lot of situations. And there was increased trust in the medical system following the launch of the AMA. However, there was a turning point in 1910 known as the Flexner Report. And the Flexner Report was kind of a hard look at the development of science and health. And what I want you to do is just to take a couple minutes on your own if you have a device with you, or in a partnership or group of three if you don't have a device with you currently, just to look at what this Flexner Report is. What is it and why did it matter? Don't need a super long definition or explanation, just a couple minutes to figure out sort of at the core of what this is. Somebody's got it and is ready to share, go ahead and raise your hand. Anybody who is able to figure out what this is would like to share? Yeah, go for it, Drew.
So he's like kind of made, he set like higher standards for how medicine is practiced and like how people who practice it should be qualified.
Mm-hmm.
And it did a lot to like change for the better how like archaic things were, like
Yeah, right. So if we think about it at the time, there's a proliferation of medical centers and doctors and so on that are developing. The Flexner Report comes out in 1910, and it's basically this damning report that says qualifications or quality that we would expect, right? Most medical centers at the time were considered to have unqualified staff, or were not considered to be doing expert or qualified medical practices. So the Flexner report was this sort of response to this proliferation of health and medical centers and saying, hey, the credibility and authority and background of these is really important. So it kind of rocked the boat a little bit, right? And it meant that a lot of the prominent medical centers and institutions that we continue to see to this day, for example, the Mayo Clinic, right, were ones that were developed in response to the support and tried to do better in the way that health and science was practiced. So if we track some of the contemporary changes, right, one of the issues that comes up all the time is the amount that the United States spends on healthcare. So looking at the federal budget of 2018, we notice that of that budget, 24% is Social Security, 15% is Medicare, 15% is defense, non-defense discretionary is at 11, Medicaid, ACA, CHIP are at 11%. CHIP is designed for helping children with receiving healthcare as well. So as a result, right, there's a lot of discussion over how the portion of the federal government should be allocated, how much we spend on healthcare and so on. But this is just to highlight that we might think that we spend a lot more on defense in this pie chart than we do, but that health and Social Security and related issues are a significant chunk of money that the federal budget is spent on. There's discussions about whether we should spend more or less, but it's a big part of how healthcare in the United States is structured, right? Also, one of the important considerations in 20th to 21st century discussions about health are social conditions, racial segregation, and disparities that have emerged in healthcare as a result. I'll touch on those a little bit more in a minute. One other change that we started to see over the past few decades is increased specialization, right? You might have a general practitioner. You also have an eye doctor. You might have a specialist if you have a unique medical condition. There's ear, nose, and throat doctors, right? There are experts that come from a lot of different fields and are more specialized. It might be who you're referred to. But while we see an increase in things like insurance and managed care, we also see costs associated with things like Medicare, Medicaid, Social Security that we are investing into. Again, as we think about particularly around the 20th and 21st century when a lot of these shifts and changes were happening, right? There have been a number of studies that have examined the impacts of things like racial segregation in disparities to healthcare and services, right? For instance, this chart here shows a combination of factors. Increased risk, for instance, ways in which there might be less care to support the needs in pregnancy among people of color who are giving birth. Also, lower quality care combined with socioeconomic disadvantages combined together to create some unique challenges and barriers related to health, right? So that's important to place in context too, that there are still stereotypes and biases that impact how healthcare is provided. Another consideration, right, is the ADA, or Americans with Disabilities Act, which passed in the year 1990, right? The ADA provides reasonable accommodation on the basis of disability. So if you have ever had to seek an accommodation in this class, right, that has only been made possible because of the ADA. But what we saw through things like the ADA were a shift away from institutionalization, putting somebody in an institution or, holding them up away from society, and instead focused on integration and incorporating people within society, right? So what we have seen over changes following the end of codified racial segregation and the end of the restrictions prior to the ADA is, while there's more integration, there's also healthcare challenges and issues that continue to exist, right? While things like segregation might not exist in a legal definitional context, they certainly exist in social and cultural contexts or in the ways in which laws are used on those bases. We'll talk more about those things in week 3 when we get into the role of culture. Another core idea here that we started to see develop, right? You've ever had to go through health insurance and that whole process, you know that that can be a little bit of a nightmare, right? Health insurance is this kind of massive, gargantuan beast. Although its overall premise is not a bad one, right? That paying into a service in order to receive lower costs on care, should a medical issue come up, is designed to overall reduce costs. It has given us a way to try to make things cost